So welcome everyone, and thank you so much for joining us in Family Council. And we have Loretta Lowe, who's our Director of Care for both Vancouver and Burnaby. So I think she knows almost everybody and everybody would know her. So anyway, so we have all heard a lot about person-centered care. So of course, we're interested in what's happening at Fairhaven and in terms of what we see with our residents. So who better to talk to us about that is Loretta, our Director of Care. So thank you, Loretta, for coming to speak to us about it. And we'd like to leave some time for questions afterwards if people do have questions. But pretty much most of tonight, the time is yours for as long as you need it. So, so welcome.
Yeah, thank you, Shirley. And I just want to say good evening to everyone again, and thanks for coming to this person-centered care topic. And person-centered care pretty much is not a new concept. It's been around for, I think, over the past 25 to 30 years in long-term care. But actually, when we try to look at the terminology and looking at the concept and the theory behind it, it's sort of like a change theory that we wanted to start putting it into practice in long-term care. In the past, probably like 25 to 30 years ago, we were thinking that, with any residents that might have cognitive disability or cognitive impairment, when we put them in long-term care, it was a very institutionalized environment. And then dementia, people would look at it as more of a non-person. People, who had lost their memory and lost a lot of their ability. So we treat them, in a certain way that when we look at it today, it was inappropriate. So person-centered care, basically, we wanted to focus on the person instead of focus on the task. So that's the main goal of person-centered care. We focus on the individual resident. Now, in the past, when we look at resident care at long-term care, it focused on the task. 8 o'clock, everybody had to get to the dining room and have breakfast, lunch, and dinner at a certain time. And if you're not done, we're going to have to clean up the table. And because you know what, we have our routine that we have to follow. The staff, they go on their breaks at a certain time. And we got to get all the dishes ready so that we can prepare for the next meal. And, at a certain time, all the residents have to take a bath. At a certain time, they all have to go to bed. All the lights have to be off by 7 o'clock and everybody have to be in bed. If you wanted to watch TV later at night, staff would tell you that, you know what, it's bedtime. Sorry, you cannot watch TV. So that's what the institutionalization of, care was like back in the days. But as we know more and learn more about dementia, it's not a normal part of aging, but we know that, a proportion of the population will get some type of cognitive impairment due to different factors. Could be genetics, could be environment, and could be, a mixture of it. And as we learn more about it, we wanted to focus on the person, and we wanted to get away from those task-focused, task-oriented sort of practice. And that's why this education about person-centered care comes about 25 years ago. There's many, many different schools of it. I don't know whether you guys have heard of something called Eden Alternative. That's one of the schools of thought with person-centered care. And mainly they focus on when residents come into long-term care, they feel that there's this triangle of issues that they would have to deal with. According to Eden Alternative, that's powerlessness, helplessness, and also loneliness. So when we try to educate staff to move away from the task-oriented focus, how do we focus on the person? We have to instill in them that every person is a unique individual. Everybody is different. You might have two residents coming in and they're both Asians. Can we make assumption that all Asians are the same? Probably not. There's Chinese, there's Japanese, and there's Vietnamese. So there's so many different type of Asians. When you look at Europeans too, there's the European population is so big. Somebody who comes from Italy might not be practicing the same culture as somebody coming from France. So I think those are the kind of type of education that we want to instill in staff. And that not everybody is going to get up for breakfast at 8 o'clock. What if somebody wants to have breakfast at 9:30 or 10? Is that allowable? Probably 25 to 30 years ago, people would say, no, you know what? That's our schedule. It's like the hospital and it's not allowed. But with person-centered care, yes, it is allowable. What we do is we save the residents' breakfast and it will be served on a tray later and it will be heated up. So that's what we do. And can we watch TV now? You know, at 9 o'clock, 10 o'clock, there's a hockey game going on and I'm a hockey fan. The answer is yes, because this is their home. It's not an institution. It's not a hospital. So that's what we're trying to move away from an institution like a hospital to more being like a home-like environment for residents who call this a second home. Of course, this is never going to be their home, but we wanted to make it as home-like as possible for residents. And that's what we're trying to educate staff on a day-to-day basis. And with all the education, Eden Alternative is one of them, but what we are putting the theory in staff is that we have pretty detailed education program, which is supported by both of our health authorities. I mean, we have Fraser Health Authority in Burnaby and Vancouver Coastal Health for the Vancouver site. And they have the same goal of educating staff in long-term care with the same type of education. And how they term it is called the dementiability course. So after staff comes out, what we wanted to instill in them is the idea of you are actually working in the resident's home instead of you are the other way around is you are not working in, no, the residents are not living in your workplace. That's what I want to say. Just want to make sure that the concept is correct here. So that's what we want to try to do with the dementiability education. And it consists of like 3 parts now. There's a course called Gentle Persuasive Approach. So, and it's a full day course on top of the care aid courses. We give this course in a 1-day delivery model. And what we tell them about is, you know, this whole concept about person-centered care. How is the brain being affected when a resident has dementia? Because dementia is an umbrella term. There's so many different types of dementia. There's Alzheimer's type, which is like 70% of the population. We also have Korsakoff syndrome, which is, you know, somebody who had, you know, a history of drinking alcohol abuse, and they would get Korsakoff syndrome, which is a type of dementia as well. Or if the resident had a stroke in the past, they might have what we call vascular dementia. And if they have mixed dementia, then it would be a mixture of it. So if the staff understand that, you know what, there is a meaning behind every behavior. They need to understand that when residents are being a bit challenging or being a bit difficult, it's not towards them. It's the disease process itself. It's nothing to do with, you know what the resident's personality is. Sometimes maybe, but the thing is, a lot of times it's a disease process that causes those kind of behavioral changes. Once they have that type of understanding, then they know that, hey, this resident actually has what we call a fractured brain. That's the analogy I usually use. When somebody has a fractured arm, you have a cast or a sling that would protect it. And we know that, hey, we have to guard this arm with very, very gentle care so that it would heal very quickly. But you can't see somebody who has a fractured brain with dementia, but the thing is, they still need the same kind of gentle care and approaches you need so that you can, you know, complete care in a successful manner and a gentle manner. So that's what this course is all about. And at the end of the day, we always make sure that staff, if they learn nothing for the whole 8 hours, that they know when to back off, because you have to wait till resident is ready before they would receive care. When they refuse a bath, when they refuse pericare, touching of their private parts, it's a defensive mechanism. We shouldn't be calling resident aggressive or violent. It does happen, but it's a defensive mechanism. It's human nature to protect themselves. If I don't know you and you're trying to touch my private part, what is going to be my first response? I have to defend myself. I am going to push and punch to try to protect my own safety. So this course teaches about that. And at the end, of course, there's some safety maneuver that we also teach the staff how to sort of break up a grab or hold from the resident in a safe manner that is self-protective, respectful, and non-punitive. Those are all the principles that we try to teach in this course. It's nothing about, judo chops or taekwondo kicks. That's nothing about it. It's all about protecting the resident at the same time. When we're trying to, when we can't de-escalate the behavior, when we do go up that hill, that mountain of physical behavior, how do we bring the resident back down? Which is to back off. And at the same time, we do need, and GPA, again, we have been telling staff too, it's for residents' family members too. Sometimes, when we have family members who would question staff, why is my mom so wet in her incontinent pad when I come in to visit? And I come in to visit, 3 times a week, and, 2 out of the 3 times they are wet. Why is that? So in GPA, what we teach the staff is that you have to explain to family member, in case resident is being resistant to care, is because of the disease process, and we have to do multiple attempts or different sort of approaches to try to get that task done. But what's in the center of this, most important thing is not just to get the task done, you have to get the task done with the resident's trust and maintaining that relationship. When we try to push through care, a lot of times we might break that relationship and break that trust. And even though residents might be forgetful with dementia, that emotional memory would stay with them for a very, very long time. Sometimes you can't erase that. So we just wanted to make sure that, family, staff, residents, we're all on the same sort of knowledge base, and we're on the same boat together, so that we can maintain that same goal of providing excellent person-centered care. So that's what person-centered care is like all about, pretty much like in a nutshell. So maybe I can pause a bit for some questions. And I also wanted to sort of touch base on, besides, the education, what other things have we done to sort of ensure that person-centered care principle is being followed at Fairhaven here? I'm sure that could be a lot of information, and I tend to talk a lot, guys. You guys can stop me anytime. I can just go over, and I can talk for quite a few hours if you let me.
maybe we're just awestruck with what you're telling us. Loretta, I'm very glad to hear that that this approach is very much integrated into Fairhaven. I'm just curious in terms of the training of staff. How is that being managed? Is this done on a regular basis, and are they rotated to make sure they're not just getting it once and then never again? So I just want to know how all this gets filtered down to the front lines of staff.
That's correct. So this particular GPA education started in 2013. So it's been about 10 years now. And I started at the very beginning as a GPA certified coach. We had to go for extra training in order to be able to train our staff. And at the beginning, Vancouver Coastal and also Fraser Health, they offer free sessions to the staff too. So they go off-site to attend those full day sessions, because on site here is only myself and a couple of my coworkers are certified coaches. So we'll be able to do it on site just in the past 8 years. Yeah. So what we're doing is that when we have new hire, of course, the pandemic stopped our training a bit. And then right now, I'm still trying to catch up with the past 2 years of staff that we've hired throughout the pandemic to get them to go through this course, because I know that, we can deliver it in a different model, which is through Zoom. But with all those, special maneuver and also some of the examples that we try to give, it's hard because you know what, you need your muscle memory with those maneuvers. And if we try to teach it, facilitate it through Zoom, I don't think that it would have the same effect as staff. So we waited till, after everything reopened, then we started the courses. So I would say that so far it would be safe to say that probably 70% of the staff has had this education. And as nurses, they have to have, in addition to GPA, what we call PIECES too. PIECES is another framework that we use. And PIECES, just quickly, it stands for physical, intellectual, emotional capabilities, and then environment, and then social. So we look at all these areas and ask 3 questions. Because in the past, again, 20 years ago, if a resident has behavior related to dementia, they're not changing the pad, or they refuse the bath, what do we do? The staff would ask the nurse, give them a PRN sedation. Again, that has changed because with person-centered care, the first thing that we do is not to use medications. The first thing that we do, we want to use anything non-pharmacological. Have we tried instead of a bath? Maybe the resident had a history of fear of water because they almost drowned at one point. So if you try to put them in a tub of water when they have dementia, that's not going to be very practical. Have you tried using a shower or do sponge bath? So those are the kind of thing that we would do with PIECES. We ask 3 questions. What has changed? When somebody has a behavior change, what has changed? Is this a new behavior? Number 2 is, what is the risk? In our special care unit, oh, you know what? He's always wandering. I said, okay, when he's wandering, is he bothering anybody? Right? When we're saying that, you know what, if he's just walking, happily pacing along the hallway, that's fine. Just leave the resident be. He has that freedom. This is their home. But as soon as if they start being intrusive to other residents, and the other residents may be getting a bit distressed of it, then we have to sort of look at what are the factors that might be contributing to that. Is the resident basic needs being met? Are they wet? Are they hungry? Are they in pain? Are they looking for something? They could be looking for a cat or dog that they used to be their favorite pet at home, but when they move into this home, they cannot bring their pet along. So there's a lot of losses there. We have to try to figure out how do we sort of fulfill that void that the resident is feeling. Sometimes, you know what, a house cat would do the trick. Lilo, look at how Lilo is a star in Burnaby. So with person-centered care, the 3 things that residents would really enjoy are animals, little tiny kids and babies, and music. These 3 things, whenever we put this combination together, you'll be surprised that residents, even with the most severe type of and degree of dementia, they sort of lighten up, and we can see a difference in how it serves in their memory. So that's what person-centered care is all about. We don't use drugs, but we wanted to use different approaches, non-pharmacological approaches, to see if we can sort of change that behavior around. But of course, sometimes with certain types of behavior or certain types of medical history, if certain residents have a medical history of a mental illness that might be triggering on top of the dementia, then sometimes medications could be used appropriately under the supervision of a geriatric psychiatrist and a family doctor. Yeah. So it's not one size fits all, but at the same time, we try to balance, those individual approaches with sort of different strategies depending on the individual resident needs. Okay, yeah. Oh, Angela, yes.
Yeah, I have a comment. We always talk about, what has changed. But I think another big issue is communication. In Burnaby, particularly on my mom's floor, there's a lot of Asian speaking, much different dialects, and a majority of the staff don't understand them. So there's a lot of yelling at times because they can't communicate and the staff don't understand. Sometimes I'm not completely fluent, but I'm often asked to try to interpret to find out what's going on. So that's another part of the person-centered care is it's not just what's happening, with their disease progression and everything else. Just communication is a big factor as well, to know what they're yelling about and to be able to figure out just to calm them down that way. So that's just my comment.
Yeah. So yeah, that's a a bigger issue. For us, we hire staff of multicultural background at both sites here, but I know that our Oriental population is going up higher at both sites. It's about 30% in Vancouver and maybe about, I would say 20%. It's going up to maybe 25% in Burnaby now. And not every shift would have a staff who will be able to, interpret. I think especially maybe night shift, but day and evening shift, there's always somebody who probably can, interpret for the residents. But what we also learned, Angela, this piece of information in GPA training is that nonverbal, it consists of 90% of the communication compared to just language use. Can I do an experiment with you guys?
Go ahead.
Okay, so raise up your right index finger here. Okay, now turn around, make a couple of circles in the air. And now I would like you to put your right index finger on your cheek.
My chin.
Chin.
Well,
You said chin.
I
cheek?
said cheek. But when
Okay.
I put it under on my chin, look how many people are putting it on your cheek. Well, I see that Shirley and Susan are actually listening to the language, but most of you are putting it on your chin. So language is only probably 10% consists of, there's research, evidence-based study to it. Yeah, so the other 90% is nonverbal. Your eye contact, your facial expressions, your tone of voice, and whether you smile. When we hire staff in my interview, I said, can you smile? Do you have a sense of humor? We don't want people to be too serious with our residents. We want a very light and happy environment for our residents, because what our residents gone through, they already have enough stress. So if you can't smile and have a happy attitude, I don't think that I'm going to hire you. Yeah. So it's very important that they have a positive attitude, not just hardworking. And they said, oh, I'm very hardworking. Hardworking is not enough. We need you to be very patient, and you have to have a big heart and be compassionate. With the rate of pay that the staff are getting, it's not bad, because union, but the thing is, it's a very difficult job. So if you're just coming in for the not very bad paycheck, that's not going to make you happy to be staying in this industry and job. It's a very physically and emotionally demanding job field that we pick, working with the elderly with cognitive impairment. So I have a lot of respect for my staff too. It's not an easy job that they're doing every day. And of course, they're not perfect. And I asked that the families would, let me know, or let the leadership team know if you have any challenges or concerns, to make it known, and then we can go through education. We can go through a lot of coaching to sort of make things right.
Okay.
Okay.
Loretta, one
Yes.
item.
Hi, David.
My mother has a bath every Saturday afternoon, and just after a bath, I'm there to visit her. Often I've been thinking, gee, what does the bathroom looks like? Is there any way I can go there? Do I need permission from somebody to be able to see that bathroom?
No, seeing the bathroom, you don't need special permission. I didn't know that you're interested, or else I would have.
No, I was just curious. I wonder how are they bathing her? Is my curiosity.
So do you want to actually witness a bath? Am I understanding?
No, I don't want to witness a bath. I just want to see the room after she's done.
Okay, next time when you come in, we definitely can give you a tour. So basically, in the tub room, if your mom is having a bath, there's what we call they call it a Rhapsody tub, and it has temperature control of the water that is coming out from the faucet or from the shower hose. And it also had a function. All the tubs that we have, they have a vibration function. So in case residents have any pressure, ulcer, or wounds, with that vibration, it can really clean off the wound bed very nicely. And it sort of give a bit of a relaxing sort of massage and sensation to the residents who's in the bath too. So that, after they have a bath, they would sleep better. So we can show you the tap, and then there's a heat lamp in there. There's also a ceiling lift motor for residents who are not able to sit up on a bath lift, so that they could be placed completely in a comfortable position to have the bath. So definitely we can give you a tour. Let me know when the next day you'll be coming in. You can let the nurses know, and then I'll just give Cherry Tree nurse a heads up.
So I just
Silver Birch, sorry.
Yeah, Silver Birch. So I just talked to the nurse at the desk and say, I talked to you, and you're allowing me to go and see the bathroom.
Yes. Let them clean it up first for you before you go in and take a look. Yeah.
Okay. All right. Thank you.
Mm-hmm.
I guess I can ask this question.
Yes, Roger. Yeah.
It may not be the exact right venue, but how would patient-centered care follow or resident-centered care follow the resident as they approach, end of life? I mean, once you start to get close to 100, I suppose by definition you're approaching an end. How can that personalized care follow that process, and how does the family get involved, and how do decisions get made? And
yes, and that's a great question, Roger. As we all understand that, and I hope that most of the family members understand that dementia is a terminal illness like cancer. Unfortunately, we still haven't found a cure for dementia yet, and we're hoping that research can advance, and in the future we can find a cure. But so far, we haven't found that yet. And so a lot of times at the end of life, it's comfort care that matters. And how we wish as healthcare giver, if all of us, if you have parents, or your grandparents coming into long-term care, that before they have that cognitive impairment, that we could have had what we call advanced directives in place and goals of care in place, so that we know what their wishes are. Because a lot of times we have residents, who are deteriorating. They can no longer walk. They went from walking to using a walker to using a wheelchair to, being bedridden. And then they, at the later stage, they're not even able to eat. And a lot of times, in a lot of cultures, food is very important to a lot of different cultures. And they said, oh, you know what? Do you think that I should be, making a decision to starve my mom and dad so that they'll be starved to death? So that's a hard decision. Some cultures say, you know what? No, I can never do that. I would rather put a feeding tube in my mom or dad. But is that the best decision? It might be to the best decision, after we talk amongst our siblings. We want to keep our mom alive as long as possible. I want them to live till 120. I don't know, right? But the thing is, does your mom really want that? Have we ever asked them? Well, we didn't ask them when they were still, alert and cohesive. Now they can't speak on their own. They can't make that decision on their own. How are we as kids to make that decision? So we have based on the quality of life. Do we want our mom and dad to be connected to that feeding tube? Because they used to, love to cook. They used to be a gourmet chef at home. Do they want to be eating, puree food now, or just be fed by Ensure, 24/7? Is that how they want to live their life? So those are some tough questions that we have to ask ourselves. Are we doing this for our mom, our parents, or grandparents, or are we doing it for ourselves? Is that because we have a lot of things that we haven't got closure about? We can't let our parents go? Or is there a lot of guilt? What is driving this decision? So we have to ask ourselves all this very, very tough, hard question. And I don't envy any family members who are put in that position. But what we're focusing on is that I wanted to support what the resident wants. And I want to respect what the family want too. But the thing is, we want to make sure that the family has all the information so that they can make that informed decision at the end. Whether they want to put a feeding tube at the end, it's up to them. But the thing is, we would tell them what are the pros and cons of putting a feeding tube in.
Is that a service that's offered at well, in long-term care in general? Is that something you have
No.
wards where people are just being kept artificially alive because their directive or the family wants that, or do they end up in the hospital?
We had cases like that, and you know, I remember one case. We have a family member who went to different hospitals and looking for a surgeon who would put that feeding tube in. He went to VGH Surrey, Memorial, Mount St. Joseph. All the surgeons said, no, your you know, loved one is not of sound mind. We cannot do that, and you know, your condition is just not recommended as a healthcare professional. But at the end, somebody at a certain hospital agreed to do it because they just see that, you know what, this particular family had gone through great length, but at the end, did it change the cause? Yes. I think the loved one lived for another half a year, but with a feeding tube, I am not quite sure whether, still to this day, not quite sure whether that was the best decision, but we have to respect the decision of the family. Right.
So once a resident stops taking in food because of dementia or old age, I suppose, then I guess then the end is approaching because they're not getting any nourishment. But
Yes.
it's a natural process. It's not something to fight. You know, it's just that's how you got to go somehow, right?
That's right. Yeah.
Can I make a comment?
Please.
So I'm with hospice, and that's one of the things that we often see when people are in palliative care or in the hospice itself. And families always want the resident, the person that they care for, they want them to eat. And in the end, what they need to understand is that if the body starts shutting down, the heart and the breathing, the lungs, are the last to go. So when you're feeding someone and making their body work in a different way, it's actually it's harder on the person. Not feeding them makes them die easier. And if you give them too much fluid, the same thing, they can drown in the fluids. So it's a lack of education on a lot of people who aren't used to the end of life and the actual process as to what happens. And so once it's explained to people that it's harder on your loved one to actually force them to eat, you know, they usually, you know, try to turn around. No, not everybody will do it, but that is something that we don't have enough education in the general public. Is that right, Loretta?
Yes, thank you, Elaine. Yeah, for filling that in. Yeah, that's great information to family members.
I think it's important, if I can just add that from our own experience, to have those conversations long time before you ever get to the point where you need to question what the person's directives would be, and having that health directive in place makes life a lot easier.
Yes.
Loretta, did you want to mention the brochures? We do have these brochures around to help with the conversation.
That's right. Yeah. Thank you, Anne, for bringing that up. So we do have some like what to do or sort of what to expect in the end of life process. At Fairhaven in general, in the healthcare authorities, they would give the same type of information, similar information. So that would help sort of family members sort of make those type of, you know, difficult decisions, what to expect, you know, at the end of life.
Also, Anne had arranged for one of the doctors at Fairhaven to come and speak to us. I think, was it Dr. Sharma? And I can't remember her name, sorry, but
Dr.
she had
Sharma.
a very, it was a very helpful session as she talked about what to expect in the process a person goes through, what, you know, when they head into that stage. So if people are interested, maybe we can plan to invite her back at some point.
Shirley, was that session recorded with Dr. Sharma?
And I can't remember.
Because if it was, then we could, you know,
That's true. We
Okay.
can replay it. Yeah.
I don't remember if that one was recorded or not. I will have to go through, and I'm making a note right now.
Okay, thank you.
Can I ask a question about OT and PT? Just reading through Shirley's minutes from the last time. I actually didn't realize that that we don't have that service, or when that left. Did I misunderstand reading the meeting minutes?
Yeah, it wasn't that we don't have that service, that the personnel had changed. So Tiffany's no longer there, and I think the PT also is different. We discussed that last in July, but I can't remember now whether there is actually somebody new. I keep asking because I do want to get hold of the OT. But I think Julia, the head of CEDIAS, I think she was filling in. So maybe Loretta can fill us in on, at least on the Vancouver side. Yeah.
Yeah, I can give you an update for both sides actually. So yes, unfortunately, we have a bit of a personnel changes at both sites. But now, hopefully, moving forward, we'll have a more stable rehab team at both sites now because we are utilizing the same provider. It's called CEDIAS Rehab. So in both Vancouver and Burnaby site, we're going to be utilizing the same PT and OT. So the PT's name is Aaron, and the OT's name is Stephanie. And Stephanie just started last week. And for the rehab aid, we did lose Bong from Burnaby, but now who we have is Sarah. And I have heard pretty good feedback about Sarah from two of our, I would say a bit of a tough critic, resident from Burnaby. And if these two residents gave their approval, then I think that I have pretty good confidence that Sarah will work out with the rest of the population. So I'll let you guys be the judge. So Bong had passed on all the tips and pointers to Sarah so that, the rehab assistant's duties and responsibilities would be fulfilled when Sarah is picking up. And for Vancouver is Ali is the rehab assistant. So hopefully we'll have a more stabilized team now for both sites. And there also been talk fresh off the press that we might be increasing some rehab assistant hands-on time with our residents because the demand is getting higher and higher. So there's talks about increasing those hours. So when we have update, we'll let everybody know. I see Anne clapping her hands right now. Yeah, and we do see a lot of positive effect on how residents' mobilities are, or even just keeping their existing mobility, preventing muscle atrophy by the rehab program. We're seeing a lot of positive effect. Certain residents in Burnaby, whom we thought that we might not be able to walk, and somehow miraculously, after 3 months of therapy, she started walking. So that it's great to see that. Mm-hmm.
Can you comment, Loretta, on the rehab assistant's time? Mm-hmm. There's one assistant per location, right? And so yes. How is that time allocated amongst the residents?
The rehab assistant right now at both sites, I think that they are doing 4 days for Burnaby and then 3 days for Vancouver. So we might be changing that time because we get like sort of one bulk budget for the rehab program between OT, PT, and also rehab assistant. But we might redistribute that because we found that, we might not need as much OT hours, but we need more rehab assistant hours to do the hands-on for the residents. So that's the sort of direction that we're heading to.
Okay. And do we have to request that service from the rehab assistant, or is that already?
No, we have what we call rehab rounds that we do once a month, which I am involved, Mary, Stell, and Bernie, and also the resident care coordinator they're involved too with the PT, OT, and rehab assistant involvement in that team, and we set the criteria. Of course, PTOT, weighs heavily on it because they do the assessment to see which resident would meet the criteria to get into the either the walking program, or they call it, muscle strengthening exercises program. So we have that criteria. If the resident doesn't really progress, in half a year or something, we have to, sort of discharge them, or maybe ask family, can you take over now that, we have sort of plateau, they call it, they have meet sort of the highest potential that they have. And we might have to ask family to, sort of take over so that other residents can have a chance to go through that program who has rehab potential to, sort of share that resources a bit. We even have family, residents who had been on a program for like 3 to 4 years. But the thing is, if they keep on progressing, they would stay on. But if they are not progressing, and that's the best that we can do, or they might go into the other direction, then we might have to discharge them. So it's all very individualized, and it really depending on the time that the rehab assistant have. We can't really admit like the whole 100 residents, in the program, right? So we have to sort of make criteria to make sure that we are maximizing the time and the potential of what the rehab assistant can do for, some of our residents.
Okay.
Sorry, I have to leave. I have to go pick up my dad, but thank you for
No problem.
the meeting. Bye.
Bye,
Thanks,
Donna.
Donna.
Have a good
Bye.
night.
Loretta,
Yes.
just to follow up on what Shirley had asked, and then your comment about whether the residents is making progress, right? But is there also consideration for maintenance? So they might not be progressing and improving. However, it's also preventing them from getting worse, preventing so that they're not, more sedentary, if you will. But having that option to have a RA for that support, I think is just as important of a consideration, because if there's nobody really helping them do the exercise, for lack of a better word, I can see that they'll probably get worse.
So maintenance, definitely. I mean, with maintenance, it also means that, we're helping the resident to remain as probably a one-person transfer or a sit-to-stand lift transfer instead of having a full ceiling lift transfer. So we do that, maintenance therapy in this program. At the same time, if we have residents who are on like a buckle bell restraint, we call it a buckle bell restraint, those residents have more, skin breakdown potential, and then the rehab assistant would come into place to play a very important role to prevent those, pressure ulcers, or prevent further deterioration of mobility. Now, for example, we have some residents, maybe about 10% of each of our largest population are on Botox treatment for spasticity. So when they're on Botox treatment, they're automatically enrolled into the restorative care program, because just along with Botox, it's not going to help with the spasticity issue of your joints and stuff. You need to do passive range of motion exercise to sort of keep those joints in check. So those residents are automatically into the program, as an example, for maintenance care.
Okay. Is there any thoughts? Sorry, is there any thought that maybe the recreation team is able to do some, not necessarily OT or PT related, but more just general exercise?
And they have that in the recreation program, and they do.
Oh, okay.
They do a group exercise program, like they would hit a huge latex ball. They do like those kind of like rubber tennis. What do you call those? A noodle, those doodle, whatever that they use in the pool.
The pool noodle?
Yeah, the pool noodle, and so they have that program, and they also have what we call morning exercises. So they would focus on the upper extremities more with the recreation therapist, the staff. So they would do that. So that's in supplement of what we're doing with the rehab assistant exercises. So they do morning exercises. If you take a look at the recreation calendar, they have that at both sites.
Okay, yeah, it's just my mom doesn't participate, so. That's where I think the misunderstanding probably goes from my perspective.
Or a missed opportunity. Some residents, they thrive better in a one-to-one environment. And
Yes.
some residents enjoy the group therapy and the socialization better. So that's why person-centered care approach comes about. You know what? We try to fit individual needs with different
Right.
programs.
Right.
Can we bring in private care now? Because before COVID, I because my mom didn't, we couldn't get enough time for her. So I did engage a private PT and a rehab person to come in, but then COVID shut all of that down. Is that available? Like, can we do that
Yeah.
now?
Definitely, as long as we follow the policy just to make sure that this is a certified professional, and they have the certification, the qualification, and they have work safe insurance. So they are properly trained, and they do have good communication with our team here. We know that what time are they going to come in and that kind of thing, and they have a treatment program that the family member sort of approve of, and monitoring at the same time with the team. Then definitely you can bring them in. Yeah.
Okay.
Loretta, how often does the PT do a reassessment, or are they just basing everything on the rehab assistant's comments?
So how often do they? So if there's every 3 months, we have what we call a MDS assessment that is required by the health authority and a provincial level by BC. So in that assessment, we call it a basic minimum data set. So in that minimum data set, it has cognitive level, mobility, intake of residents, the disease progress, all that kind of in different sections, and we are supposed to code it. And the PT and OT and nurses, we all code our own different section, and at the end you might get a score or something like that, so you can see the progress of that. And so in short, every 3 months, and also when there's a condition change of the resident, if they come back from the hospital, or if they had a fall, without going to the hospital, but you know what, somehow their mobility or their cognitive ability had changed, then we would do a reassessment. Yeah.
Loretta, you just mentioned the recreation schedule.
Yes.
And I just noticed, like, I think if starting September, there were a bunch of them printed out. And I found that very useful, like for myself, to know what activities were happening and maybe to suggest to my mom or show it to her. I put one up in her room even. She still does read and understand words, and she gets mixed up with the days of the week and so on. So it is in a calendar format. So I don't know, for my mom, it's a great tool, I think. And then for me also, when I'm coming to visit, I might try to come when Rachel's playing because she's so great. I find it therapeutic, honestly. But yeah, I mean, I'm not sure if that was just a one-off or you're planning to continue to print out a few of those, like for October and November. Of course, there can be changes. It may not be 100% like reliable, but and I guess I could also add to that, like the newsletter. Obviously, it's more directed at family. But I've printed it out, or I've showed it to my mom on my computer, and it's interesting content to see what's going on to the degree that the resident is capable of understanding it. But if they see their image there doing an activity, and that is a reminder of what they did, and I don't know, I think that would be a good thing to share with them, the actual residents, if they're show some interest.
Roger, I can speak on that. When you walk into Burnaby Fairhaven, if you look left, all of the schedules for every of the Carnation, Rosewood, Marigold is there for families to grab. I always have one in my mom's room, and sometimes the recreation staff actually will deliver one if you want one. And also, I did see a resident reading the newsletter, so there's a copy on the second floor for residents if they want to read the newsletter too. So they do have it.
Okay, that might just be a communication thing, or I didn't ask until now.
No, but if you walk into the entrance, you'll see they print it off every month.
Okay.
No, that's good feedback, Roger, that wasn't drawn to your attention. And also too, we are looking to add the calendars to our website, so then people will be able to go on and access the calendars for each neighborhood on the website too.
And do you know, for the menu, is that laid out like a week in advance, or is that planned out like a month in advance?
It's the spring summer menu. It's a 5-week rotation, so it just rotates every 5 weeks back to week 1.
So is that posted anywhere in terms of like the weekly rotation?
It should be posted in every dining room. In fact, hold on, I have a copy here. It looks like this.
Okay.
So
Okay.
you should see that posted in every dining room, or should be available in every dining room. With that, it can get complicated posting it on the website, just because every week I'd have to remember to go on and post the week. And I sometimes get busy. It's not to say I can't do it, if that would be helpful. I saw Angela shaking her head. Are you saying they're not posting it in the dining rooms?
No, there's not a week one on the, they'll post what's for lunch and what's for dinner, but it doesn't show you what's for the week. I'm not sure where I got it, but I have copies from the 2021 fall and the spring. And so I know exactly what it is, and I take a look what's on the menu, because I visit my mom. I live in Nanaimo, so I come over for a week at a time, and I look at what's on the menu, and I know what she won't eat and what I will bring to supplement.
Right.
But apparently someone said it was, I haven't found it again, but I think it's on our website through resources, so I'm not sure if it's there, but for the spreadsheet that should be available to be able to print off. I did do it a couple of years ago, and I still have it, and pretty much it hasn't changed between that previous spring to the fall.
Yeah.
For the most part, it's pretty consistent.
Yeah.
Sorry,
So,
let me add something here. I think that I have seen this one on the front desk when you enter to the Fairhaven in Burnaby. It's on the front desk. You can pick up from the front desk.
Okay.
When you sign your name, so it's on the desk.
The other thing, Anne, just to maybe save you some work, is if you post it on the website, and maybe you have also like an annual calendar, you just put week 1, whatever correspondingly, and then we just kind of look up, oh, like today is like this week corresponds to week 3. So we can just look at week 3 to see what the menu is there. So it's not like you have to keep updating it every 5 weeks, but rather you have the full year laid out. And then we just kind of know which week is which.
Yeah, the problem is where they switch over from spring, summer to winter, fall. It doesn't line up week 3 to week 3. I don't think. I think they do something there. So, but I mean, it's not a bad idea. I can explore it for sure. For sure.
Yeah, like I just don't want it to be a make work project for you. But maybe if it's only twice a year, then it's not so bad if that's when you update it.
Yeah, definitely.
Thanks.
So the topic of food and person-centered care came up, and we had a big discussion about this at our last meeting. Is it, and I understand that given budget and how do you manage, different people's abilities to their dietary needs and their ability to eat and so forth. But is there any way that we can work with whoever's managing the food services side to look at ways to bring a little bit more variety or choice for residents who might prefer that? Because it is really difficult for residents who, come transitioning into long-term care, and all of a sudden they have to eat a prescribed menu, and it might not even be to their tastes according to their either cultural background or whatever it is. So we talked a lot about how we can improve in that area, and who can we work with? What do you need in order to bring back or to give people a bit of a selection? Or so can we talk a little bit about that? Can you guide us in how we can make something happen in terms of food services?
So I am not sure whether the Family Council is aware that our Director of Food Services at Retire, Elizabeth Shimchuk, right? So the new organizational structure is that we have a manager of support services who look after food services, maintenance.
No, housekeeping and laundry.
Yeah, housekeeping and laundry, not maintenance, housekeeping and laundry. So they are at each site now. So we just wanted to make sure that, you know what, they learn about the organizational culture first and sort of get into the routine first. Then we're going to invite them to probably join in the family council so that the family members can give some feedback about, you know, what menu selection would we like, what kind of a menu would we, you know, want to explore. Probably in the new year, because there's talks about that they wanted to actually change some of the menu items, and of course we have to, you know what, do some objective data collection first, because you said that, you know, so and so doesn't like this, so and so doesn't like that, but what is the actual percentages? Maybe what we wanted to do some wastage audit. Measure the food scrap, for example, measure the drinks that we are serving, you know, how much are we wasting every time? You know, every time when this menu item is being served, my God, we got a whole buckets of food scraps. So why are we still serving that? So we need to do those sort of data collection first and do some auditing with the residents. And then we can get back to our drawing board and look at what kind of new menu items can we explore. And that would be the time when we would be inviting you guys to give your feedback.
Loretta, can I suggest that you look at not only the hard data of food wastage, but maybe the staff can do some observational soft data, you know, because like in my mom's case, she might not like something, but cohesively, she knows that she has to consume this food for fuel. She might hate it, but she will still eat it. So you're not really measuring whether the food is to her taste or not.
Yeah. Well, your mom might be, you know, part of some of the percentages on it. So the soft data, definitely, we're going to provide both qualitative and, you know, quantitative data that we'll be looking at. So probably maybe more survey will be coming your way too. We just don't want people to feel having a survey fatigue.
Yes,
done so many surveys in the past year. So we just want to give you guys a bit of rest before we're going to give out those survey again to change our menu. But definitely we're going to include both soft and hard data.
Okay, thank you.
And I flew too in the short term. I know Dana in Recreation, our director of Recreation, is really trying to expand some of the food clubs and certainly around international food, so that it's in a small way at least can kind of help with that situation where there's varied diets and varied, you know, wants and needs. So the Recreation's hoping to help out with that.
Yeah, and thank you to Anne. You just sort of prompted me, cue me for mentioning about a Fairhaven Cafe that's going to be coming up. I forgot the exact date now. We just talked about it this morning. Sorry.
I have it. I'll get it.
So this Fairhaven Cafe, we have done it in our Vancouver site, but now we're bringing it to a Burnaby site. It's sort of like an informal forum for family members to get together with our recreation, or maybe, I don't know, maybe we will be inviting food services too. So this is a forum that you can sort of give your feedback on our food selection and choices on menu too. So that would be maybe a first step. And then once we get all our hard data and soft data together, then we're going to move forward with some menu changes. But I would really encourage all of you, the Burnaby family members, to come and join this Fairhaven Cafe.
Yeah, it's November 7th at 2 p.m.
November.
I just want to mention, sorry, that with all these activities, it's really difficult to attend when you're working full time. So for me, the barbecues in the summer, the garden parties, whatever, those are all great, but it's really hard to find the time to fit it in on a weekday when you're working full time. So if there's any consideration for having something, say on a weekend, or, you know, or early evenings, would be really appreciated.
My final question, Loretta, when we talk about person-centered care, is how do you measure the success of it? Like, are you meeting your goals?
Yeah.
We have 30 seconds. We have.
So and Edward has his hand up too.
Okay, so I think some of the more measurable data would be, I would say, the number of what we call responsive incidents of residents to staff. Okay, so that would be one hard data. If staff are using the correct approach and the right approach, they back off, they, use different approaches and creative approaches to approach care, then we're going to see a lot less of those. The WorkSafe BC data, like how many WorkSafe BC claims do we have? Okay, so those are some examples of whether our person-centered care education is, working out, and whether our principles are being carried through from theory to practice. Also, we can also see that from other data, like I don't know, like whether, weight loss of residents. I mean, we measured like every 3 months too, on our MDS data. If residents are, having more than 5% weight loss, it would be reported. And with, feeding assistance and, having different variety of food, look, of course, taking into consideration about the residents' progress of their disease process, then we take into the consideration of, do they have dramatic weight loss or it slowed down? So did we make a dining environment very conducive to them consuming food? So those would be, sort of some of the hard data that whether we know whether, our person-centered care approaches are working. Yeah, so those are a few examples that I can think of at this point. Yeah.
Lots more to talk about. I'm conscious of the time. It's 7:32. So are there any other last-minute burning questions before Edward's waving? Edward?
Yeah. It's going to be very quick. I'm looking at the minute from last July and talking about the air conditioning I'm preparing for next summer. Okay, so what's the conversation we had in July? Like, should I just go ahead and plan to apply to have, a portable air conditioner for my dad, in his room, or any changes or anything that we're doing next year that I should take that into consideration before doing that, or just want to see what's the...
So, Edward, I am sure that you're aware that in the common areas, we already have the split AC system in Vancouver that was installed last year. So this year, thank God we don't have like a severe extreme weather of a heat wave. So it's much more manageable this year. But of course, in certain residents' room, the temperature is still, maybe not at a comfortable range according to certain individuals' needs. So what we do is we don't have any other plans of putting in any other AC system because because of the building structure, we can't put central AC in there. So it's not going to go to the residence room. So what we do is we encourage you to, you can put in a portable AC if you want, or you can put in more fans. And the staff also know to, keep residents, out in the common area until, their bedtime, before, all the curtains would be open again with the sun setting, and then the whole room would cool down before they would place them to bed. So they might have a later bedtime during those hot summer days. So those are the instructions. And also we have very extensive heat management plan that we follow from both health authorities about hydrating residents, because besides managing their comfort level, hydration is extremely important. And that we would, give sponge bath or cool baths, as necessary, as needed. But please go ahead and do that. But you need to go through our maintenance and put in a request, because there is, I think, a bit of a cost to cut out those plexiglass. We can't just sort of close the window with some paper and then put the heat exhaust pipe there, because the hot air is still going to come back into the room. So we have to do it properly with the plexiglass, and the maintenance guy will be able to help you with that.
That would be good, because I got the forms and everything, but one thing that I wasn't too sure is that in that form they're talking about you have to take it down every fall and then put it back in again the next summer, or
so
it's something that you can just leave it alone. And so,
no, because I think that if you just leave the AC there, it's catching dust. Our housekeeper would have to, sort of dust it every single day. So it would be too much. Yeah, and then it's taking up space. We don't want the space to be cluttered.
Okay, no, perfect. Another quick question that I have is from the July minute as well. So that's talking about the recreation activities, and there was some question about you know, sharing some of the time of, for example, like Alice, who speak the language, and I know my dad miss her after she get reassigned to another wing. Okay, so so I just don't know is there anything that we can do to be more flexible instead of, you know, having certain language advantage of Alice, and somehow she get assigned to something else, and other people who can benefit from it and doesn't get the benefit.
Yeah,
So
I
instead of,
second
I
that.
guess my question is that we have a variety of different resources, and everybody's great. You know, I love working with all the recreational staff, but some people also have a different skill set, and how do we not to limit the benefits that the team can bring together, you know, instead of partitioning up or dividing or assigning them to a certain wing, and they're stuck there for a year and then end up that, you know, I'm just a question for everybody to think about, you know, because we have a diversity of different resources, right? Just like, you know, doesn't matter healthcare or engineering or whatever, you know, different skill set. How can we leverage that pool of resource so that the end users, the people, or the residents can benefit from it?
Yeah.
You know, instead of divided, okay, let's only stick in this area, and person A staying in the other area, and for a couple of years before get Day back.
Yeah. So Edward, sorry, you know, let me see if I can try to condense it into a 30-second answer.
Yeah, so
Because of lack of time. So it goes back to person center again. Okay, so what we have at Fairhaven here is we do have a staffing model that is called a neighborhood model. So we want to try to assign the same staff to the same neighborhood, and recreation the same thing. I am not aware that, you know, Alice have been reassigned from one neighborhood to another, but
I don't know.
Yeah.
Because a couple of years ago she was used to be there every
Yeah.
time I show up, and now I just don't see her. I thought she get a. It's my assumption. I could be wrong.
Yeah.
Edward,
You know,
you
I
are
thought she get assigned
correct.
to another ring.
Yeah.
Edward, you're correct, because Alice told me that she's been assigned to a different neighborhood, so you are correct.
Yeah, I don't know. I just assuming, and I'm from Alberta too. I only show up once a month. So I just don't know. I just don't see her. That's all.
Yeah, so we would try to see if we can, you know what, sort of share resources. But the thing is, the consistency of staffing is one sort of principle about person-centered care model. So, and I see what you mean about, you know what, having somebody to speak the same language who had, you know, worked with your dad for 2 years right now, she moved away. It's really difficult. So we will have to maybe have more conversation with the director of recreation, just to see why that decision was made, and, you know, what influenced her to make that decision. So we might have to dig a little bit deeper with that.
Yeah, definitely. What I'm asking for is everybody's great. You know, all the people that I work with is fine. It's just that for my dad, he doesn't speak any other languages. All he knows is Cantonese, and
I think there's
so
enough,
he's pretty quiet right now. He's stuck.
This opens up another topic that we can go on for another hour about. So maybe we need another session to talk about this, because in terms of person-centered care and how it relates to culturally appropriate, cultural and language appropriate care is another big issue in a diverse population like ours. So anyway, so I think I'm really aware that I would used up your time and more, Loretta. So thank you. And I'll let you speak if you want to finish that off, and then I'll close the meeting and let people go.
I'm done. So thank you.
No, we can plan to have another session as well. I mean, we obviously have a lot to talk about.
Yeah, that's right. But anyways, thank you for inviting me to tonight's session, and it's been a pleasure, and it's really great to see so many family members show up, and then I get to say my piece about, you know, person-centered care, and what sort of our mission of Fairhaven is all about is in our mission statement. And I hope that, you know what, we can actually put that mission statement in practice when we are, you know, working here at Fairhaven, that it goes through the frontline staff and it shows. And again, you know what, we're not perfect, definitely, and we like to hear your feedback if there's anything that we can improve upon, because we are looking for quality improvement at all times. How do we make our residents' lives better on a daily basis? That's our goal. That's my whole sort of being here. So yeah, so it's been a pleasure tonight, and I hope that everybody, you know, sort of got something out of tonight's session. If you don't, I'll try my best later on next time. But yeah, that's it. So have a good evening, and you know, my office, I have an office in both Burnaby site and Vancouver site. So Monday, Wednesday, Friday morning, I'm usually at Burnaby site. Tuesday, Thursday, Friday afternoon, I'm usually at the Vancouver site. So drop by and see me if you need anything.
Great.
Or just
Thank you,
a call.
Loretta.
Thank you, Loretta. Thank you,
Loretta.
Shirley. Thank you, Anne.
you.
It's
Thank
really
you, everyone.
valuable tonight.
Yeah. Just a heads up for next meeting, guys. Dr. Drance, Elizabeth Drance is coming back
excellent.
in October. So she's open for suggestions or your questions. So send them on to me if you have anything, you know, for leftover from last time. For those of you who didn't take in her session, I would highly recommend that you come. She's a very engaging speaker and has lots of really good, you know, down to earth things to talk to teach us, and she's great. So please come. I'll send out more information towards next month. And I think we've run out of time. So as I keep doing every month, I push off agenda items to the next month. So there's nothing urgent. So I will cover it next month. Thank you.
Awesome. Thank you so much, Shirley.
Okay,
Appreciate
thanks.
it.
Okay,
Thank you.
see you guys
Bye-bye.
next month.
Have a good
Bye-bye.
evening.